Thank you, Larry. I'm going to talk about an area in MR that's an exciting area, still is not widespread in clinical practice, and I'll share a few reasons why. However, has been really important for many centers that do advanced cardiovascular imaging, and this is in the development and application of 4D flow imaging. We will talk about the rationale for 4D flow imaging and the clinical applications. And certainly there's a lot of interest in minimally invasive vascular imaging. This is an area that CT it contributes a lot to, and MRI can as well. We will talk about the basics of phase contrast after reviewing some of the background, which is interesting regarding flow MRI. And then important developments of 4D flow imaging that now make it a clinical reality that is patient-friendly and can really contribute to the diagnosis in these patients. And then we'll talk about some applications of 4D flow, including qualitative flow imaging and quantitative flow imaging. This has been a subject of a lot of academic publications, many from our organization, UW Radiology. And here are three cover figures from JMRI, AJR, and radiology, all using the 4D flow technique. And I'd say while these are important research publications over the last 15 years, now these are really incorporated in our practice into standard clinical routine. And the rationale for this, of course, we know that CT provides excellent morphology, and it's quick, it's easy, and it uses radiation. Of course, here's a patient with a partial anomalous pulmonary venous return returning to the inferior vena cava. MR, on the other hand, has excellent functional information. It's relatively slow, although the 4D flow techniques are now faster, and it's challenging to post-processing, but it doesn't involve any radiation. So here's that same patient with that anomalous pulmonary venous return, as you can appreciate here. This is a 4D flow. This is a dynamic acquisition, and it's remarkable at how much additional information beyond just the anatomy of the partial anomalous pulmonary venous return. So, of course, on MR, we can see that abnormal systemic artery feeding a sequestered area of the lung that then is being drained by this anomalous pulmonary venous return. And once we see that, these patients with anomalous pulmonary venous return, we want to know what the quantity of flow, and it's possible to do that all after this retrospective acquisition of a single 4D flow data set that we can retrospectively identify what the quantity of flow through that vessel is. As we continue to rotate this around, then we're interested in the associated atrial septal defect that is often seen in these patients with partial anomalous pulmonary venous return. And in this case, we can tag flow through that ASD and quantitate where that flow is going, as well as the quantity of flow, because in this case, that ASD will also need to be corrected at the time of the correction of the partial anomalous pulmonary venous return. Now, in order to decide on how to correct that ASD and when to, we also want to assess the pulmonary to systemic flow, the QP to QS. And these techniques also allow us to do that. We can then zoom in on this area and place a cut plane through the pulmonary artery and the aorta. And here we measure the flow in the pulmonary artery as 4 liters and the aorta as 3 liters, indicating a shunt over 1.5, which tells us that that ASD should also be corrected.
The next talk that I will be delivering is on PIRADS, and how many of you guys are doing, let's say, more than 5 prostates a week? Okay, so this has been a big change. I started doing prostate in the 90s, and we just did a handful of those, and it was a very, very difficult situation. We were trying to focus on extracapsular disease evaluations. And it was an okay, diagnostic study, but we did have some trouble with that, and it took a long time until diffusion-weighted imaging came to the fore, and that really transformed prostate imaging to the point now, in our practice, we're doing at least 5 every day. So it's a very robust practice, and in fact, when you combine it with in-bore biopsies and MR ultrasound fusions, we're really delivering new levels of good care for patients. So I'll be talking to you this morning about PIRADS, and while PIRADS is very thoroughly described, I'll be going through how to go about a few cases, but also highlighting some of the areas that aren't quite clear, and I'm sure everybody's encountered those. Just to begin with, I do want to acknowledge many of my colleagues who have been instrumental in bringing excellent prostate imaging to UT Southwestern. So let's just start with a little background and remind ourselves about the histology, because we talk about clinically significant cancers. And that's the key here is, we don't want to detect every single cancer. What multiparametric MR has delivered has been a lower detection rate of clinically insignificant cancers and a higher detection rate of clinically significant cancers. The histologic analysis is really a pattern analysis, as indicated on the right-hand portion of your slide, and looks less and less like normal prostate cells as the Gleason score number goes up. But more recently, the popular way of looking at it is in the Gleason group grading. And here you can see that if we have less than 3, it gets a 1, the 3 plus 4 now a 2, etc., and you can read the rest. But this is largely where we're migrating. So you'll see through this talk, I'll be indicating going back and forth between these two elements. In addition to the Gleason grade group, what we're going to also be looking at is the percent of each core that is positive, and in different practices that has different meanings. But in general, the higher the percent core, the more significant the cancer is likely to be, and then the number of cores. The reason the urologists are thinking about this is who are candidates for active surveillance. That's really one of the key issues. And then, of course, as we ultimately go into this, how many cancers are there? What percentage of the gland is positive? Is there anything outside the gland?
These are my disclosures. Nothing really pertains to that for that presentation particularly. So when we think about what do we do for diagnosis and staging, well, mammography and DBT nowadays and ultrasound are still the primary diagnostic tools we have for staging our patients. What do we want to tell our surgeons? Well, what is the size of the tumor? Is it unifocal, multifocal? What is the lymph node status? And also, in particular, if the patient is going for neoadjuvant chemotherapy, which a large proportion of patients actually is currently going to, and also with neoendocrine treatment pushing into the realm, is the clip actually appropriate? Because the intent is when the patient responds, you want to be able to offer the patient breast conservation afterwards, and you will still have to do a surgery. So we want to know, is the clip in the right position or for planning the surgery in the end? So when you look at that, that is pretty simple. In this case, do we need an MRI? I personally would think no, not really. This is a unifocal lesion which is well visible on ultrasound and mammography. So we can really do well with that. Yeah, so same case here. After neoadjuvant chemotherapy, that is the reason why we really need to know where the clip is. This lesion is gone, yeah, but I still will have to localize something to offer my patient breast conservation and an assessment, how was the response. So the problem with mammography and sonography is they can underestimate lesion extent. And also, if the patient is not such an easy case with a non-dense breast where I can see the tumor easily, then it gets a little bit more tricky, and surgery planning can be difficult and can also result in the end of the day in unnecessary, or not unnecessary, the revision surgery is necessary, but it would have accurate planning beforehand would have obviated positive margins. And I think in this case, it can be really clear why we are particularly limited in women with dense breasts. In this breast, I don't even know if the woman has a cancer or not. This is yes, a wild guess. In screening, I probably would say this is a normal exam, and still there can be a massive cancer in there. So for staging, and these are the easy cases. I have a thing for medical paintings and medical stuff. So here we see two images where actually the cancer is actually visible from the outside, but often this is not the case. So in this case, this is a patient, I can already confidently tell you she has a cancer. So where would that be, in your opinion? Who's for the right side? Left side? Well, in MRI, it's pretty visible that this patient has a massive cancer, which I wouldn't have seen to start with the mammogram. So, and this is where MRI can really, really add something. This is another case. The woman has an extremely dense breast, when at the hint at the side is already what is going on in the axilla. When we go back, we can say, well, the nodes are here way more prominent. This is actually how she actually found her cancer. She palpated something in the axilla. She actually had, from quite like a few months ago, actually a normal screening mammogram.